encephalopathy. Okay. What is the definition? Neonatal encephalopathy is a clinical syndrome that it's a disturbed neurologic function in the earliest days of life. And the definition is greater than 35 weeks with subnormal level of consciousness, seizures, and often difficulty in commencing and maintaining respiration, and decreased tone and reflexes. Okay, but the question is the same neonatal encephalopathy and hypoxic ischemic encephalopathy? I shared the point of view of Dr. Volpe. I think that neonatal encephalopathy is an inadequate term for hypoxic ischemic encephalopathy because multiple magnetic resonance imaging studies of term infants with the clinical setting of presumed hypoxic ischemia near the time of delivery have delineated a topography of lesions highly correlated with that defined by human neuropathology and by animal models, including primate models and hypoxic ischemia. These imaging findings, coupled with clinical features consistent with perinatal hypoxic ischemic insult, warrant the specific designation of neonatal hypoxic ischemic encephalopathy. What it means? I think that neonatal encephalopathy, it's a way of naming and neurological dysfunction, but the etiology can be diverse. For example, if you have one organic accidemic with neonatal encephalopathy, I prefer to use the term metabolic encephalopathy. Notice this, I think it's very different. Hypoxic ischemic encephalopathy is the same. It's a neonatal encephalopathy caused by perinatal asphyxia and has altered level of consciousness, muscular tone, tendon reflexes, and seizures can be clinical and electrical. Okay, we start our protocol Nuculin in 2013, and today, and the inclusion criteria is newborns greater than 35 weeks, more than 1,800 grams. We are using the classification of Garcia-Alix, I will explain later, with Apgar equal or less than 5 at 5 minutes. Continued need for resuscitation, including endotracheal or max ventilation at 10 minutes after birth, acidosis with pH less than 7.0 from cord or patient blood gas within 60 minutes of birth. Abnormal base excess is equal or less than 16 milliequivalents per liter from cord gas or patient blood gas with 60 minutes of birth, and abnormal EEG pattern prior to hypothermia for more than 30 minutes. Okay, we are using the rating scale of Garcia-Alix because it's very reliable and it's very easy. The clinical items that we are using only is alertness, muscular tone, motor responses, reactivity, and clinical seizures. And the previous version of this rating scale, it was in 2018 and includes the aEEG recording. It's very important, the value of background pattern, because you can establish the relationship with the grade of hypoxic ischemic encephalopathy. And when it's a normal aEEG recording, the normal or moderately abnormal, you are talking about a mild grade. Moderate grade has a moderately or severely abnormal, and severe hypoxic ischemic encephalopathy, severely abnormal background. Okay, what it means this? Because I think that we need to be more explicit in this case. The mild abnormal recording is a pattern continuous and discontinuous. Moderate abnormal is discontinuous, bulk suppression, low voltage and flat. And the seizures can be present in only in clinical and in electrical recording. And severe is the pattern of bar suppression, low voltage and flat. And the seizures maybe can be present, okay? The new rating scale, it was published in April of this year and include the alertness, posture, muscular tone, spontaneous motor activity, motor response elicited by stimuli, and includes myotatic reflexes. This is the tendon reflexes, breathing pattern, clinical seizures, amplitude integrated electroencephalographic seizures on clinical and electrical seizures, and the background pattern of aEEG. This is Alfredo Garcia calls this rating scale that is asymmetric, but if you can see, the score is 0, 1, 2, 6, and 8. What it means that what is the form to make the score? If you have a score 0 to 8, it's a mild encephalopathy. 8 to 30, it's a moderate in more than 30, 31 and greater, it's a severe. I think it's very important, this classification, but because and today we have more I don't know how to say evidence. I don't think that it's a strong evidence that the mild encephalopathy maybe can be treated with hypothermia. I think that in our countries, in developing countries, we don't have all the accessories and the equipment to make hypothermia and mild encephalopathy, and we need to use more clinical tools like this to distinguish between a mild and moderate encephalopathy with a more reliable. And I think this new rating scale, it's very important and very strong predictor, and we can distinguish perfectly between a mild and moderate encephalopathy. I think that severe encephalopathy, we don't have problem in to recognize this kind of clinical. Okay, now what happened with aEEG? Okay, this is an aEEG and in window time. This is before hypothermia, and you can see this pattern, like a snake is a continuous pattern. Okay, and when start hypothermia in our protocol, we are using like sedation, morphine or fentanyl. When we don't have morphine, we use fentanyl, and you can see the change in the background pattern. Yes, it's now looks like a discontinuous pattern with a lower border below 5 and greater border, it's greater than 10. But it's very important because this when we finish the hypotherm and the sedation, the pattern will be recovered to a continuous pattern. Okay, this is that I tried to explain what happened with some medication and in the background pattern when we are using phenobarbital, sedation, and hypothermia. This is a stairway, and when you are using phenobarbital, sedation, or hypothermia, you can make one job step by step. If you have a continuous pattern before the hypothermia, maybe you can change to discontinuous, and this is normal. If you have a discontinuous pattern, you can change to burst suppression. If you have burst suppression, you can change to low voltage, and finally low voltage to flat. But be careful if you make a jump of 2 steps. What happens with 2 steps? If you are using anesthetics like sevoflurane, maybe you can make this jump of 2 steps, continuous to burst suppression, or you have a severe neonatal encephalopathy. What it means, if you have one baby with continuous, for example, this continuous pattern before the hypothermia, and when you start sedation and hypothermia and sedation to conventional dose, and you make this jump of 2 steps, this continues to low voltage, be careful. That it means this is a severe brain damage in this baby. Okay, the antiepileptic drugs like phenytoin, fosphenytoin, levetiracetam, topiramate don't change the background pattern. You can see it remains in the same step. Okay. In our hospital, we reproduce this protocol of Sorensen and was published in Pediatrics in 2010. Effect of hypothermia on amplitude integrated electroencephalogram in infants with asphyxia, with criteria of cool cap and normothermia 31 versus hypothermia 43. And what is the result? Okay, in our protocol, we make the same design, and it was the time and the time window 3 to 6 hours, 7 to 12, 12 to 18, 18 24 hours, 24 to 36, and finally to every 12 hours until 72 hours. It was our first 2 years of protocol. We include 52 babies with selective hypothermia. When we start our protocol here in Mexico, we were using a cool cap. Mental index between 70 to 84, and severe disability, mental developmental index less than 70, and death. What happened with the blue line is the protocol of Sorensen published in Pediatrics, and this is in our protocol. Okay, in this you can see the predictive positive value of abnormal traces for a bad outcome. Okay, you can see in both research the predictive positive value when you start hypothermia not is consistent with the final outcome. But if the abnormal pattern persists across the time and it's abnormal pattern between 36 and 48 hours, the positive predictive value for a bad outcome in our protocol, it was 80%. For Sorensen, it was 92. And when the abnormal trace persists more than 48 hours, it was 100%. Okay, this is very important because I think that the abnormal pattern, if you are watching an abnormal pattern more than 48 hours, does not matter the etiology of encephalopathy. The prognosis is bad, and I will try to explain with other clinical examples later. Okay, recommendation. When you start hypothermia, decrease amplitude by hypothermia per se, and use of sedatives. This is the decreased amplitude. Background pattern before hypothermia in the window time, in the first 6 hours, not have correlation with neurological outcome. Normal aEEG during window time plus hypoxic ischemic encephalopathy moderate to severe. If you have a normal aEEG, the positive predictive value if the baby remains in normothermia for a good outcome is 67%. 2/3 of the babies have a good outcome, and 1/3 not have a good outcome. If you have normal aEEG during window time and you make hypothermia, the good outcome is in all the babies. This is published in pediatrics. If you have an abnormal aEEG during window time plus hypoxic ischemic encephalopathy, moderate to severe, the positive predict value by normothermia for bad outcome, abnormal aEEG and bad outcome is 86%. If you make hypothermia with abnormal aEEG during window time, bad outcome decrease to 56%. Okay, what it means this, EEG is an inclusion criteria, but not exclusion criteria of hypothermia. What it means, okay. If you have a normal aEEG in your baby, but you have the clinical evidence of moderate to severe, and you start hypothermia, you can make a good outcome of your baby in 100%, okay? A normal aEEG nor excludes your baby of hypothermia, but it's a help to make an inclusion criteria. Okay, look this evolution in this baby with hypothermia. Eight hours, and the 48 hours, you can see this pattern is a discontinuous pattern with some cycling variation here. It's more the bandwidth span is broader, and here and here is broader. This is like discontinuous pattern with starting cycling sleep wake and 72 hours. Okay, you can see start in a very bad pattern, abnormal pattern, almost flat, and the evolution, it was good, and 48 hours you can see a discontinuous pattern. Okay, the baby is under hypothermia and sedation. Okay, and what was the result? Okay, with the result, it was good, but I have other clinical example. I only it's an explanation that if you see a bad pattern when you start hypothermia, not it means a bad outcome, because the hypothermia has this possibility to modify the final outcome in the neurodevelopmental. We have 168 newborns in hypothermia since January 2013 in our protocol New Cooling. This is other evidence of the use of aEEG during hypothermia, but in my personal point of view, notice don't like, because this is a number of latency factors. Okay, what was the time of the pattern change to abnormal pattern to discontinuous pattern, and what it was the prognosis in these cases. The good point of this change to abnormal to discontinuous pattern, the good point, it was 15 hours, and the area under curve, it was a good area in 0.74, but cycle sleep wakefulness, the good point, it was 45 hours, and finally to recover a normal pattern, the good point was 78 hours. I think these cutoff are very late, and the area under curve in this case of cycling sleep wake, it's not as strong. It's I think it's better the discontinuous pattern. I prefer to use the evolution across the time, the recover the pattern to normality. It's very, when you use only one factor of latency, you don't have a good prognosis. But when the combination of the three factors, discontinuous pattern, normal pattern, and cycling sleep wake, it was strong. When and the gold standard, it was the damage in the MRI, and you can see when you set the three factors, the number of abnormal MRI, it was greater, but not demonstrated one significant difference between no severe brain damage. Sometimes in our hospitals in developing countries, not only in Latin America, it's difficult to make one MRI. In my case, in my hospital, we don't have MRI in our hospital. We need to transport the baby to other hospital to make an MRI. I have an ultrasound 24 hours to make cranial ultrasound. I resolved my problem of brain image with ultrasound, but the aEEG is a very good predictive tool, not invasive tool, and sometimes it's very, in our countries, it's sometimes accessible. The accessibility, it's good. Okay, clinical case. This is that happens in our protocol. In our protocol, we have young mothers. This is 17 years. It's first pregnancy, dystoxic delivery, female, 2,565 grams of 39 weeks. Sorry, upward 0.2, and pH 6.8. Bicarbonate with the measurement, it was too low. Base excess without measurement. The classification of hypoxic-ischemic, it was severe. Start selective hypothermia. The baby develops an bilateral pneumothorax, and this is, we are using the cool cap system. And at 8 hours, you can see this pattern is an abnormal pattern. It's like if you see like discontinuous pattern, but in some times you can see this basal line with the tooth, like breast suppression, and starting with scissors. With this is the spike slow wave you can see in this case. At 8 hours, the scissor it was electrical, only electrical. But to 48 hours, recover to a continuous pattern with slave wave cycling. And what was the final outcome? Okay, this is the baby after 72 hours to finish hypothermia. And the baby after 1 week of life, you can see the scar, this. Discharge after 11 days. The diagnosis it was meconium aspiration syndrome, bilateral pneumothorax, hypoxic ischemic cardiomyopathy, and seizures. The outcome, Bailey 2, 8 months. It was MDI 114 normal, PDI 90 normal. This is the baby at the 10 months. You can see the scar here. Here, no, I can see here, but he has the scar in both sides. And this is the video. Okay. This is the video of the baby at 10 months. I don't know what happened because but this is a baby with a normal developmental outcome. And it was important because we are using the aEEG like a very strong tool to prognosis in our protocol. This is our case. It's a moderate hypoxic ischemic encephalopathy with the status epilepticus plus hypothermia. You can see the clonic movements of the hand, and you can see the graph elements is very repetitive, high voltage. Okay. And this is the pattern of the aEEG. In this case, you can see this maintain elevation of amplitude. That is like an epileptic mountain. And the spike wave, the graph element in the raw EEG. And it's very important because when I need to make one clarification. In Mexico, we don't have intravenous phenobarbital. It's a very complex situation. It's a very political situation. It's not that we are working with the neurologic society and neonatology society to improve this situation of the intravenous phenobarbital, but it's a very I don't know, with sad situation in our country. We don't have intravenous phenobarbital. Sometimes we are use lidocaine or midazolam, and you can see this in this baby. When we start phenytoin intravenous, and the seizure activity, it was persistent. When we use midazolam here, you can see the change of the background. It is very typical, the change, and you can see one continuous to discontinuous pattern. And after the midazolam, you can see this broad suppression pattern, and you can see the graph elements in the raw aEEG. When we make this investigation, seizures like marker for bad prognosis, disability, or death in newborns with hypoxic ischemic traits with hypothermia, we found that the seizures during hypoxic ischemic encephalopathy treated with hypothermia nor is a marker of bad prognosis. The sensitivity and specificity was very low, and predictive, positive predictive value and negative predictive value, it was too low. And you can see this relative risk factor below than 1, but not it means that it's a protector factor. That it means that if you, when you start hypothermia, and when you have seizures, and you continue the monitorization, and you can make the outcome of your treatment, and you can see, when you see one electrical seizure, doesn't matter, you need to treat. Please, always, when you see one electrical seizure without clinical manifestation, you need to treat every seizure. It's the same, even in the term infant, around 50% of seizures are only electrical. This is very important. And I think this is the explanation of our results. If you have a baby and in hypothermia, and you have to continue monitoring, when you detect one seizure and you start the treatment, you can modify the final outcome. Okay, well, now we're gonna review aEEG in preterm infant. Okay, please watch this video and watch. Okay, this is a preterm infant, 28 weeks. And the baby have one intraventricular hemorrhage, and we start monitorization with aEEG. And I am looking for a clinical manifestation of seizures. If you can see one manifestation of seizure, of clinical seizures, please say me, because I don't see anything. This is very important, because what happened in his brain? Okay, this happened. The baby has an intraventricular hemorrhage with parenchymal lesion, a very extensive parenchymal hemorrhage, you can see, and the baby don't have any clinical manifestation, and the baby and it's very why this is the main trials evaluating aEEG and neonatal outcomes in preterm infants. You can see 1, 2, 3, 4, 5, 6, 7 trials, and the age, it was very similar, below than 38 weeks, mainly. And what was the indication of monitorization? It was MRIs grade 3 and 4, 3 and 4, 3 and 4, 3 and 4 on leukomalacia, white matter lesions, periventricular hemorrhage. And what happens? In resume, intraventricular hemorrhage produce an amplitude decrease, increased discontinuous pattern, breath suppression, and seizures. It's very important because if you have a baby with severe hemorrhage, grade 3 and parenchymal lesion, you need to make one monitorization because around 70 to 80% of the seizure in preterm infant are subclinical, are only electrical. It's very important to make the monitorization of preterm infant with structural brain damage. The prevalence of seizures in preterm infant is around 6 to 80%, and 84 to 90% are caused by structural brain damage. What is the main structural brain damage? Intraventricular hemorrhage in the first 5 days of life. aEEG can detect 50 to 70% of seizures in premature infants associated with structural damage, but monitoring should last 24 hours to detect subclinical seizures and continue 24 hours after they have been controlled. This is very important. The most of seizures in preterm infant are only electrical, and you need to make one monitorization when you see intraventricular hemorrhage. Sometimes we have a lot of patients, a lot of newborns that need one monitorization, and we don't have enough equipment. My recommendation is if you are watching one hemorrhage grade 3 and 4, please start monitorization even you don't have clinical manifestation of seizures. Okay, it's a very interesting topic to me. I am working my main research line in this moment is bilirubin encephalopathy. What is the bilirubin encephalopathy? Is a neonatal encephalopathy plus total serum bilirubin more than 20 milligrams per deciliter. It's equal to bilirubin encephalopathy. I am using the term neonatal encephalopathy, not is equal to hypoxic ischemic encephalopathy. I was using this term like a generic name of diverse etiologies of this encephalopathy. Okay, what is the epidemiology in our countries, in developing countries, or around developing countries? The kernicterus in developed countries has prevalence of 0.4 to 2.7 for each 100,000 of live births. What happens in Latin America, especially in Latin America? Chile. Chile is the most important economy in Latin America, and the prevalence of kernicterus is around 11.8 for each 1,100 live births. This is very different that in developing countries, and Chile is our best economy. Okay, what happened in Mexico? In Mexico City, in a cohort of 300 babies, 20% have hearing impairment with total serum bilirubin more than 16 milligrams per deciliter. In my hospital, especially in my hospital, we have 7,000 to 8,000 births per year, and we have 5 to 6 cases of kernicterus per year. That it means 47 for each 100,000 live births. This is 20 times more than this. It's very important. It's a difference very significant. Okay, and what happened with the aEEG? Change in amplitude integrated electroencephalography, neuron-specific analysis, and S100B protein in neonates with brain injury induced by neonatal hyperbilirubinemia and their significance. It's very interesting research made in China. They have 2 groups, the brain injury group and the no brain injury group. The brain injury group has a bilirubin level around 26 and 28 milligrams as 483 millimoles, and the no brain has around 13 14 milligrams and 258 micromoles. It was a very significant difference between the 2 groups of the levels of bilirubin. When they analyze the aEEG result, you can see the abnormal pattern in between brain injury group and non-brain injury group. It was very significant. Remember, moderate abnormal pattern is equivalent to vasopression pattern. It was very frequent, and I think the vasopression pattern is the abnormal pattern more frequent in all the etiologies of neonatal encephalopathy. And you can see the difference in the normal pattern between no brain injury and brain injury. It was a significant difference. When they make the measure of protein S100 and analyze, the difference was significant between brain injury and non-brain injury. But it was very interesting that the correlation, the R of Pearson, it was a very direct correlation between the pattern of aEEG and the levels of analyze and the levels of protein. This is protein S100, and this is analyze specific. And aEEG has a direct correlation between these measurements. Okay, and aEEG not is invasive. In this case, they make the measurement in serum levels of protein S100 and analyze. Okay, this is a typical case of my hospital. A young mother, 16 years, first pregnancy, male, of 39 weeks, breastfeeding exclusive. He was admitted to another hospital with total serum bilirubin to 20 milligrams per deciliter. The blood group, mother O positive and baby A positive. Okay. On admission, TSB, it was 29, CUMS, it was positive, and reticulocyte count 3%. But the baby, it was with stupor, hypoventilation, hypotonia, and without seizures. And the aEEG, you can see, it's very important. Please see the date. And the background pattern, it's a vasopression pattern, vasopression plus. And you can see the vasopression, the burst of activity and suppression of interburst time. This is interburst time in the left and the right side. But the baby after 7 days. TSB remained to 24 milligrams per deciliter after 2 exchange transfusion and 2 doses of intravenous immunoglobulin. It starts with automatism and tonic seizures. In the video, you can see the automatism and the oral automatism, and the baby. When we see this restart or monitoring the tonic seizures, okay, and the aEEG, okay, please. The previous trace, it was 1 week ago. Now, 7 days after the start monitorization, the baby remain in blood suppression pattern with seizures, clinical and electrical. Okay, what it means this? If you have one abnormal pattern, if you have a persistent abnormal pattern after 48 hours, no matter the etiology of neonatal encephalopathy, the prognosis is bad. And this is the final outcome. This is the same baby at 6 months, and you can see the spasticity of lower extremities. You can see the gastrostomy, the opistotonus, and it's very typical clinic of kernicterus. This is a baby with kernicterus. Okay, another example of aEEG application, aEEG in growth restriction. This is a baby of 28 weeks, 800 grams. And the neonatologist asked to me for a cranial ultrasound. But it was interesting that it was a very very preterm baby, and they don't use oxygen or CPAP and everything. It was okay with the baby. And when I see the face, I think not was a normal baby. When I make the cranial ultrasound, I found a lot of circumvolution, a lot of gyrus, and a very important marker of gestational age is the temporal operculum. It was closed, completely closed, and the operculum closed around 28 weeks, and the gyrus, the cingulus gyrus, it was too long, and the calcarine gyrus, it was very long too. And what this means that notice 28 weeks baby. When we start the aEEG, we found a completely normal pattern of continuous pattern with mature sleep-wake cycling without seizures, with no seizures, suggestive of more than 36 weeks. When I asked about his mom, the answer was he is in the intensive care unit by a hepatic cirrhosis. And the main etiology of hepatic cirrhosis in our countries is alcoholism. What was the final diagnosis? Fetal alcohol syndrome. Yes, this baby with a growth restriction. Yeah, and you can see the baby has a flat philtrum. The upper lip it's thin, and the face is flat with this the canthus is prominent, a very, very typical phase of fetal alcohol syndrome. This is what explanation, because not is a preterm infant, it's a growth restriction. Okay, we got continuous with brain malformation. This is very interesting trace because you can see in the left side, you can see clear this pattern of a lot of mountains, epileptic mountains, and these mountains in the right side, maybe you can see like cut, not is very established the pattern like in the right side. But it is very important to make the difference. When you see the raw EEG, you can see this slow waves rhythmics of high voltage around 200 microvolts. And remember that the upper limit of voltage in the EEG is only 100. This is explanation because in the right side you don't see clearly the seizure activity, but in the raw EEG you can see that the main seizure activity is in the right side. Okay, and what happens with the brain? The brain have a hemimegalencephaly, okay, in the right side. Okay, this is the MRI, and you can see this hemimegalencephaly that is associated to hemihypertrophy of body and this vascular malformation. It's equivalent a Klippel-Trenaunay-Weber syndrome. It is a syndrome with one pathology in migration, neuronal migration is altered and produce this hemimegalencephaly. But in this case, it's very important to make the difference in the raw EEG. You can see that the main seizure generator is the right side, not is the left side, but in the EEG, you can see this activity more clearly than the right side, but it's very important to make this valoration of EEG and the raw EEG to demonstrate what is the main generator of seizures. In this case, the right side. Okay, this is very EEG in perinatal stroke. Okay, look these videos, please. And you can see these clonic focal seizures of the right side. Okay, in the right side, you can see when the nurse tried to stop the movement continues. This is very suggestive to seizure activity. And this is in other moment, the baby with the same movements. Okay, clonic focal seizure is very important because the clonic focal seizure have a direct relationship with perinatal stroke in around 50 to 60% of the cases of perinatal stroke. Okay, what pattern you can see in this? Okay, you can see in the remember the movements, it was in the right side, and the seizure activity is in the left side. This, remember, that is a decussation and is in the brain, and the left side produces the movement of the right side of the body. And you can see this activity, these mountains, these repetitive seizures in the left side with a pattern of discontinuous pattern, background pattern, you can see, and it's the generator of seizure is the left side. But it's what happened if the same baby, but in other time, this is the date, July 26 at 1 p.m. And this is in the other day, and the 1 day later, you can see in a transversal montage. What are you seeing? I think it's a very normal pattern, a continuous pattern in a baby near a full term with no doesn't mean nothing. But at the same time, in the same baby, if you see the same trace in a longitudinal montage, you can see the difference between two sides. In the left side, an abnormal pattern in these cases, and discontinuous with this is like a breath suppression pattern, and the right side, it's a continuous pattern. What is the sad, the side with the pathology or with altered or with a brain damage? We need to investigate with neuro image the right side, because he has an abnormal pattern. When I make the cranial ultrasound, I found this zone of this region of hyperechogenicity in temporal lobe and involving the basal ganglia here and the and some of frontal lobe. This is the MRI. You can see one sequence T1 and T2, and you can see this hypo-intense, this sound of hypo-intense signal in T1 and hyper-intense signal in T2. And when I was evaluate the diffusion sequence, you can see this zone of diffusion restriction suggestive of the thrombosis of cerebral medial artery in the left side. It's very typical image of a prenatal stroke due to thrombosis of medial cerebral artery. Okay, this is the angioresonance. Is very typical. Okay, and this is the one paper that we published in Journal of Maternal and Fetal Medicine. Usefulness of two-channel amplitude integrated EEG recording in a neonatal setting, and we recommend the use of two-channel because you can see in the same baby at the same time. Maybe you don't you don't detect the alteration in the background pattern, because when you make an evaluation in transverse montage, the high amplitude is strong and the pattern is predominant in the high amplitude is predominant in the pattern, but not it means that everything is okay. You can see the same in the same this example in a transversal montage. Maybe you don't you cannot see the scissors, but when you at the same time you change a longitudinal montage in the right side, it's an status epilepticus, and in diffusion sequence, you can see this restriction of diffusion, suggestive of the territory of medial cerebral artery, and it's very typical. This is the other side of my case. Okay, aEEG in microcephaly and intracranial classification. Remember that in America, we have an epidemic of Zika virus. This is not, it's a case of Zika because in my city, we don't have Zika because we are altitude around 2,200 meters, and the vector of Zika virus only lives around less than 1,000 meters. We are in the more than this altitude, and it's different. This is a case of a microcephaly with an intracranial classification, and the diagnosis, it was a torch syndrome. You can see the microcephaly, you can see the air, it's not as a normal form, it's like alpha, and the spasticity of the lower extremities. This is the cranial ultrasound, and you can see a lot of calcification, periventricular calcification, and a lot of intraparenchymal calcification. The cranial tomography, you can see this, a lot of parenchymal intracalcification, a lot of intraventricular, periventricular calcification, and periaqueductal calcification too. When we start the monitoring, it's a term baby with suggestive more than 40 weeks or near to 40 weeks. Yes, this is a cradle sleep, it's active sleep, but we start to identify these mountains. And in raw aEEG, we found these slow waves, rhythmic slow waves. And this is and the date was February 2. And we continued for 24 hours the monitorization, and we found this mountain again 1 day later. And in raw aEEG, you can see another time the slow waves rhythmics. We start antiepileptic drugs. It's very important because in a report of seizures in intracranial classification, around 77% and 100% of the babies have seizure activity in the electroencephalogram, and you need to make one monitorization of babies with intracranial calcifications. This is an example of myoclonic seizures. What happened with myoclonic seizures, because the duration of myoclonic is very short. The myoclonic seizures are very repetitive. You can see the association between the movements of myoclonic jerks and finally the brain activity. And when the baby make the movement, yes, the movement, and finally you can see the activity. And the relation, this is a kind of video electroencephalography because I am demonstrating the activity and the clinical association. Okay, this is the pattern, the background pattern you can see is breath suppression with these mountains, and we activate recognition software, but the software no make any marker. Why? because the activity in myoclonic seizures sometimes is very different to seizures between seizures. Maybe you can see one spike and a slow wave, and in the other seizure you can see 2-3 spikes and one slow wave, or only see slow waves, rhythmics, and it's very different. And remember that the software recognizes the 5 waves with the same shape and the same amplitude is when start the marker. Okay, this is an example of the use when are treating seizures. In this case, we start phenytoin, a dose of chairs dose of phenytoin, and you can see this mountain, 1, 2, 3 mountains, and after when finish the infusion of phenytoin, the pattern recovered to continuous pattern. But and when I explained in the start weight slide, the phenytoin don't change the pattern after the use of this antiepileptic drug like phenytoin. They remain the normal pattern. But if you use midazolam in this case, you can see it was an status epilepticus. There is a mountain of activity duration is around 30 minutes. And we decide to start midazolam in a bolus of midazolam. And you can see the change after the use. This is the pattern before the use of midazolam, and it's a pattern like discontinuous to continuous pattern. And after we use the midazolam, change to breath suppression. Yes, it's very, and it's recovered across the time. This is a discontinuous pattern, and at the end recover the normal pattern. Okay, and finally, aEEG application. All newborns will alter consciousness when are suspected seizures, clinical and subclinical, to the value effectiveness of epileptic treatment in preterm infant with structural brain damage, intraventricular hemorrhage mainly, prognosis in hypoxic ischemic encephalopathy with or without hypothermia, assessment of neonatal encephalopathy, no matter the etiology, and abstinence syndrome. In my special point of view, the aEEG is a brain screening. It's very important to me. And finally, thank you for your attention and thank you for your time.
Thank you, Dr. Cesar. So we have